So we'll be discussing our first case today. He's a 24-year-old male patient who is a student presented with complaint of left hand weakness for 2 months. On examination, there was a decreased grip in left hand and powers were 3/5. Rest were unremarkable. Subsequent MRI cervical spine was done on 18th of Feb 2026, which showed a 3.4 into 6.2 centimeter left eccentric elongated lobulated intramedullary lesion extending from the superior margin of C5 to the superior margin of C7 with edema, and no cystic component was noted. So this was the pre-op MRI. So these are the T1 images, axial images. Here we can appreciate a lobulated lesion in the contrast images.
Should I continue?
Yes, Dr. Sham.
All right, so these are the axial T1 weighted images. These are not post-contrast, or these are prior. The upper row is pre-contrast and the row is, okay, this one is unenhanced, right? So unenhanced, we do not see any significant lesion. However, there is subtle bulge on the left side, which appears almost iso-intense to the rest of the spine. So as we move forward, on post-contrast, we can see this eccentric lobulated lesion in left hemichord, which is kind of expansile, and it is showing a kind of heterogeneous enhancement. On axial T2, we see that the lesion is heterogeneously hyperintense and it is causing significant edema, as you can appreciate in the lower row. The edema is central and the lesion is expansile with heterogeneous signals. Next. So on T1, we can see again the lesion appears iso-intense and we see a little bit of expansion of the cord and edema extending upwards as well as below the lesion. Next image. So on post-contrast, what we see that the lesion is showing homogeneous or heterogeneous enhancement with lobulations, and it is kind of eccentric with significant edema above and below this level. On T2, again, we can appreciate that the lesion is expansile and it is eccentric with the proximal and distal edema. So in this, you can really appreciate the edema is reaching up to the cervicomedullary junction and distally up to the proximal thoracic cord. Okay, so the differential based on these images is that of an astrocytoma because it is eccentric and it is expansile and it extends for more than two vertebrae. But in this, the lesion is relatively almost reaching the two vertebral height. And the closest differential is that of the ganglioma, but that is mostly found in children.
Okay, Shyam, what would be your differential ganglioma?
With astrocytoma, the other differential will be ganglioma.
Okay, so what would be your most preferred differential in terms of descending order?
The first will be astro because again the based on the age of the patient, because the patient is adult, so astro will be the first differential.
Okay, so this patient underwent bilateral partial laminectomy plus excision, and which was done on 17th of Feb 2026. And biopsy, it was reported to be as high-grade glioneural tumor, IDH wild type, WHO grade 4. Then he was referred to oncology for further management. His post-operative MRI spine was also done. So these are his post-op MRI spine images. Dr. Shan.
So here again on T1, and the upper row is T1 unenhanced and the lower row is post contrast. So again you can see that the distal some of the portion of the lesion is still enhancing, and that is a residual tumor. as appreciated in the lower row images. Next. So these are the T2 weighted images. The lesion is shown as an expansile residual lesion with persistent edema within the cord. And we also see laminectomy defect posteriorly with a scar. Next. So here we can see laminectomy defect extending from C4 to C6 and with postoperative changes and subcuedema, and then a little bit improvement is seen in the cord expansion. Next. This is post contrast again. So the enhancing area is the residual tumor, and with some improvement in enhancement, of course, decompression has also been performed. Next. So on T2 sagittal, we can appreciate that there is significant improvement in cord expansion and a bit improvement in edema. However, the extent remains the same, and the lesion appears heterogeneously hyperintense. Next. Over to you.
A subsequent MRI whole spine and brain was done, which showed post-op contrast enhancing lesion as discussed by Dr. Sharan, which is around 3.3 into 0.7 with diffuse edema. 1.2 into 1.2 centimeter fluid thickness were focused at level C6 levels, and there were non-enhancing laminectomy changes noted from C4 to C6 spine, and there was diffuse edema in paravertebral muscles and subcutaneous tissue of the neck. So biopsy was re-reported, and it was reported as high-grade glioma with features favoring towards astrocytoma WHO grade 4. So our question from the board is regarding the further management of this patient.
So my first question would be from Dr. Fauzan. Dr. Fauzan, if you kindly tell us something about from the surgical point of view, because looking at the post-surgical, post-operative scans, it seemed to be not a complete resection. So is it possible to get further resection in this patient?
Well, this is a diffuse sort of a tumor. This is astrocytoma. It's very diffuse on T2 as well. So, I mean, I don't think we can completely take it out. And at the moment, his powers are okay. I mean, he's got left upper limb weakness, but he's intact. And I think they did it without neuromonitoring. So they usually in part of the world they just do a biopsy without neuromonitoring. That's how they do it. But I think there is a high risk deteriorating neurologically if we further do an aggressive tumor resection, and revision surgery is always unpleasant. So I think we should, and obviously
Dr. Fauzan, we can't hear you.
hello.
Yes, you are
Yes.
audible now. We lost your voice in the middle.
Oh, oh, I'm so sorry. So I'm saying that this is a very diffuse sort of a tumor, and they have I mean, this is a diffuse tumor, and he's got weakness in the left upper limb. Neurologically he's able to walk, etc., but there's a very high risk of him deteriorating neurologically if we go in again.
So my second question would be regarding this because there are two components in the radiological scan. One is the enhancing component, and the other is the diffuse edema associated with it. So clinically or operatively, because you have experience in doing spine surgery, what would be your insight regarding about this swollen component? Would it be the part of the tumor itself, or sometimes it is just the inflammatory component that is sometimes associated with the high grade astrocytoma?
Well, what we usually do is we resect the contrast enhancing part. This is a very diffuse sort of a tumor, so it's not completely resectable. Also, uh, The contrast enhancing solid component is the main. Well, because spinal cord is different from brain, because uh, in brain, or every part of the brain is not eloquent. Spinal cord is eloquent throughout, because all the nerves are all the tracts are passing through it. It's a difficult sort of a this is a difficult sort of a surgery. I think if I would have gone in for I would have aimed for a more uh, more radical resection with IONM, but he's weak on the left upper limb, and I think he will be on a very high risk for further deterioration.
Thank you, Dr. Pradhan. Dr. Shah, my question from you is regarding, because if in brain tumors, whenever we have these flare changes or edema associated with a contrast enhancing component, usually the literature suggests that it could be a part of the tumor itself. So the same principle applies to the spine as well, or it is somewhat different radiologically? Would you please give your insight? Thank you.
Yes, I agree with that because based on the grade of the tumor, because it is a high grade tumor, and so definitely the non-enhancing component must be there based on the expansion, there's significant expansion on of the cord as well. So and we do not actually see any syrinx formation. Basically, it's more of an edema and white matter changes, or sorry, flare changes. So this is highly likely that the non-enhancing component of the tumor is there besides the enhancing component.
Thank you, Dr. Shah. So, Dr. Munib, my question from you is regarding the further management, because this patient is 24 years old and the initial biopsy suggests neuronal tumor, but the age is somewhat different because usually we see neuronal tumor in the young children. So that's why we have requested to get a second opinion from the our institute regarding the histopathology, and it turned out to be a high-grade astrocytoma. So how would you actually proceed with treatment in this patient? Thank you.
Thank you, Dr. Asim. I think considering it's a high-grade glioma, definitely this patient requires adjuvant radiation therapy. In spine, again, the delivery of radiation prescription dose for the glioma is quite challenging because of the spinal cord tolerance. In this scenario, because the primary target area is the spine, I just wanted to confirm that before that whole MRI brain was done before to rule out any primary brain disease.
So we got a MRI brain as well as the whole spine. It turned out to be negative for any drop metastasis.
Okay, okay. So again, so for regarding the radiation therapy, I can see the extent of the lesion. At least I would say that the gross residual disease, and I am after discussion with the radiologist, I would recommend at least 54 gray in 30 fractions. Again, if there are any postoperative changes, non-enhancing component, again, the length of the cervical cord, minimum dose I would recommend is 50.4. But if at the gross level, I would escalate dose up to 54 gray.
Okay. Because we don't have any medical oncologists with us, but considering the astrocytoma, Dr. Mani, would you consider adding some uh, systemic treatment to this patient as well?
Yes, I think the management will be like the high-grade glioma. So, like the temozolomide, we usually recommend concurrently in adjuvant setting, extrapolating from the primary brain tumors. So, yes.
Okay, thank you, Dr. Mani. Because this high-grade astrocytoma in young adults is not a very common entity. And unfortunately, by behavior, this tumor seems to be aggressive. So whenever they were found a lesion in the spine, the recommendation would be to get the first thing would be get a surgical evaluation and the biopsy and the maximal safe resection that possible. because it is a spinal tumor, and so that's why we need to actually rule out the whole neuro axis as well. And sometimes we also need the CSF cytology in order to see the CSF for any abnormal cells, because from radiation perspective, the radiation treatment we would change depending upon the positivity of the CSF and all this kind of thing. So, but the treatment management would remain same. This patient require actually the concurrent chemoradiation therapy as mentioned by Dr. Munib. The challenge would be because of its location in the spine, which is for high-grade astrocytoma. The recommended treatment is to give a higher doses like 59.4 to 60 gram. But in spinal cord, these are our limitation. So we need to be actually confine ourselves to the dose of 54 gram. So because there are two components in this particular case, one is the flare changes that are flare changes, and the other is contrast enhancing. And because the flare changes has a quite extent, because it is started from the upper end of the just from the paramagnum going to the thoracic up to the thoracic inlet or the thoracic spinal cord. So that's why we have to actually cover all this area with a little bit margin. So that's why we need to actually see whether it is possible to cover the whole thing in a single 54 volume, or need to be divided in the sequential phase, for example giving 45 to the whole basis pair changes, and then move towards a higher component of contrast enhancing that would require a dose of at least 54. I totally agree with Dr. Mani. Um, so now we can move to our next case, Dr. Fabio.
Yes, Dr. Asim.
Sorry, Dr. Shan, do you have any question?
Yes, I had a question from Dr. Fawzan regarding the surgery. Like, there has been a decompressive surgery, and the radiation will cause a lot of edema, and that will be helpful. But what about the stability, would there be mechanical instability in the long run because the patient is quite young? I think Dr. Fawzan is not with us.
Yeah, I think it's just a two-level laminectomy. I don't think after two-level laminectomy we need any stabilization. Also, in tumor cases, we usually avoid putting in screws or implants because it causes the MRI further done would cause some implant metallic implant effects. So we usually avoid putting in any screws in tumor cases.
All right, thank you.
Thank you, Dr. Fazan. Yes,
Thank
Dr.
you.
Fabia, please proceed with the next case.
So we'll be discussing our next case. He's a 26-year-old male patient, right-handed, KPS 90, presented with complaint of headache, vomiting, and walking difficulties for almost 3 months. His MRI brain was with contrast was done on the 17th of Feb 2026, which showed heterogeneously enhancing lobulated lesion of foramen magnum, compressing medulla, and cerebellum. So Dr. Shan, please.
All right, so these are axial T2-weighted images in which you can see that there is a lobulated lesion in the posterior fossa, which is predominantly arising from the fourth ventricle and minimally extending into the right CP angle. And it is showing a surrounding CSF cleft around it. And it is also causing obstruction at this level, resulting in proximal obstructive hydrocephalus. Next image, please. So the lesion appears relatively iso-intense to gray matter on T1, and it is showing homogeneous intense post-contrast enhancement. Can you move back to the T2 image? All right, so on T2, we also see some signal hyperintensities in the lesion and clearly, if you can appreciate on these limited images. So these areas of signal loss are secondary to underlying calcification within the lesion. Next. Next. We do not see any significant abnormality in this area. The meninges look fine. There was no meningeal spread of the disease at this point in time. Next. So you can appreciate that the lesion is lying very close to the floor of the fourth ventricle and CP angle, close to CP angle. The roof is relatively clear of the lesion. Next. Here you can appreciate this focal area of hyperintensity within the lesion in the lower aspect. So that represents calcification other than the lesion is purely extraaxial. Next. So based on the imaging, the differentials will include ependymoma versus choroid plexus papilloma and medulloblastoma. But looking at the diffusion weighted images, there was no diffusion restriction. So medulloblastoma is less likely. Then we have to decide between the papillary ependymoma and the choroid plexus papilloma. So based on the features, the lesion appears very lobulated. It is not like a plastic tumor, it's not behaving like an ependymoma. It's behaving more like a choroid plexus papilloma. And it is also showing very homogeneous and intense enhancement as well, which is very typical, appearing very cauliflower type, lobulated. The first differential will be that of choroid plexus papilloma, followed by papillary ependymoma. And of course, medulloblastoma is all totally out because there's no restriction within the lesion.
So, Dr. Shah, I have a question regarding how to differentiate choroid plexus papilloma from the ependymoma on and
Ba-
radiologically.
Yeah, based on morphology and the extent, because the lesion is both are lying in the same region, like they are extraaxial within the ventricles or lateral foramen. But the choroid plexus have a typical lobulated cauliflower appearance, which is so this tumor is behaving like that. But ependymomas are plastic tumors, so they do not make a lobulated lesion. In fact, they spread like a toothpaste, insinuate into these areas. So the morphology really helps in this. And choroid plexus papilloma may give diffusion restriction as well, but the ependymomas don't give diffusion restriction.
So, if I would like to ask you about your differential in terms of descending order to ependymoma, what would be the first differential or the choroid plexus papilloma?
Choroid plexus papilloma will be the first differential.
Okay, thank you. Thank you.
So this patient underwent suboccipital craniectomy plus maximal septal resection on 23rd of Feb 2026. Histopathology reported as neoplastic lesion with papillary configuration and osseous metaplasia. Differential diagnoses include choroid plexus papilloma, CNSWH of grade 1, and papillary ependymoma grade 2. Post-op MRI brain with contrast was done on Feb 2026. Post-surgical changes and near total resection of the lesion was reported. So these are the post-op images, Dr. Shah.
So on post-op, we can see that there is resection in the suboccipital region, and you can see the surgical track extending up to the lesion. So most of the right half of the tumor has been resected, but we see a curvilinear residue on the left side. Next image. So on the upper row is unenhanced and the lower row is enhanced image. So you can see the enhancement along the resection cavity, along its inferior as well as left lateral aspect. So this is the residual tumor. Next. You can see the tumor is also within the foramen of Leschka on the right side. Next. So these are again the similar images. So here I think you have tried to show that there is some enhancement along the vestibulocochlear nerve complex, which is post-op because these changes were not present initially. So this is most likely reactive change to the cranial nerves. Again, similar, you can appreciate that the lesion, the residual lesion is enhancing, and I think two-thirds of the component has been removed, but one-third is still there. Next. So FLAIR images, you can appreciate the lesion, the resection cavity is appearing dark while the tumor around the resection cavity appears bright.
So a spine MRI was also done. These are the T1 axial images, Dr. Sham.
All right, so these are the T1 weighted images. Here you can see hypo-intense, relatively iso-intense area in the distal thecal sac, which appears T2 पे T2 नहीं है आपके पास अच्छा okay, so on T2, if you can see that this area appears hypointense in the distal thecal sac, and it is not matching the signal intensity of the primary tumor. So, since it is hypo and iso on T1, so this is most likely post-operative hemorrhage, which has settled down into the thecal sac, and that may cause chemical meningitis and arachnoiditis and post-contrast enhancement. So this is not behaving like a drop metastasis. These are mostly post-surgical hemorrhage within the thecal sac because this is a post-operative scan done on the third day, probably third or fourth day. I'm not sure.
So, Dr. Shyam, there's two components. One is the initial one that I've mentioned. There is a immediate post-op, but this MRI spine is actually was done once we know the histopathology that is the ependymoma. That's why it is ordered to have to get the whole neuro access evaluation. So this was done almost 4 weeks down the road. So this was not an
4 weeks.
immediate. जी, जी.
हाँ तो फिर आप देखें तो फिर तो और मतलब it's more confirmatory that enhancement हो सकती है आराम से क्योंकि blood production will cause these changes. ये 3 days से 6 weeks तक हो सकती है enhancement इसमें.
Okay. Okay. So radiology, it is not look like
Dropment,
drop
yes.
mat.
But you can confirm with cytology and short
Mhm.
follow-up so that these changes may disappear then.
Okay.
So
Yes, I
Can
agree.
you go back? See on, no, sorry, the last image, T2. Can you see the hypointense area in the distal most thecal sac? Yeah, this is all blood. The tumor will appear hyperintense. G Fozan, sorry.
Oh, so I agree. I mean, we can follow this patient up with with an MRI maybe in 6 weeks' time.
So the important thing is that because the histopathology report showed it's a papillary ependymoma, grade 2. So for
Mm.
grade 2 ependymoma, if there is a cross-total resection, even still you require radiation therapy. The only challenge would be regarding whether it is a localized one or it is to get a whole cranial axis imaging or cranial axis radiation therapy. So that would be a decision-making important perspective from our end. So that's why it is all done. We don't have the CSF cytology with us. But the important thing is that, Dr. Fazan, looking at the post-operative MRI, because there is still some residual disease associated at the primary site. So any rule of re-resection in that particular situation?
So sorry, I just missed your question.
Because at the primary operative site, there is some
Mm.
residual enhancement or lesion. Is it possible to, for what is your opinion regarding the resection of that particular area?
I think the resection is okay because this is a very risky area.
Hmm.
So I mean, going in again would be again a bit of challenge. और ये मुझे बताएं ये स्कैन कितने दिन के बाद हुआ सर्जरी के?
I think it is also done because we don't have this any immediate post-op MRI available at that particular time. It was done down the road, so it was done, I think, more than 3 weeks down the road.
3 weeks down the road. So yeah, I mean there may be some element of post-operative change as well, but I mean it looks like there is some residual. But I think this is a very difficult area. They have done a good resection. It was a big tumor. So I think we should go ahead with the radiation.
Because the important thing is that the histopathology is also something, because papillary ependymoma is not a very common entity.
Hmm.
It is not it is one of the rare differential that one can think of. That's why we had a very detailed discussion regarding this thing. And because there is also on the CT scan, though we haven't attached that scan image here to also show more calcification. Um, so that's why the term papilloma is considered in the differential. That's why all this thing required we have ordered the whole neuro access evaluation. And one of the important thing is that there is also some so considering the, because it is a papillary ependoma, because that's why it is very important thing I have asked previously as well, whether it is a choroid versus papilloma versus ependoma, because the management is quite different. For ependymoma grade 2, definitely the radiation is the next line of management. However, for choroid plexonoma, you don't need to involve radiation at a particular time, and you will have to proceed with you just need to regular follow-up. But
So,
looking at
Dr.
the
Asim,
Gigi.
radiologically, calcifications can be present in choroid plexus papilloma as well. So, is it possible that we get some expert opinion on histopath from outside?
Let me discuss
Because
with
radiologically,
hmm.
it's favoring papilloma, choroid plexus papilloma more than ependymoma.
Okay, okay. So I will again request with our primary uh, histopathologist to actually get a review in their pair. So we have a basic, because the management is different for both the thing, as I mentioned earlier. So because this is one of the interesting cases, that's why I presented here, so that we have quite an opinion from all the experts. Thank you everyone.
Thank you.
So this is the last, I think this is a last case. So we don't have any more cases. If someone has any question, they can ask. Otherwise, we can conclude our team report for today. Thank you.